All right, welcome to your lecture about upper obstructive disorders. So in this lecture, we're going to discuss three upper obstructive disorders: laryngotracheal bronchitis, it's a mouthful, or LTB, croup, then epiglottitis, and foreign body aspiration. So croup is typically caused by a viral infection, which is often parainfluenza, and it results in swelling of the upper and middle airway. So it's primarily pharyngeal, laryngeal, and tracheal. Croup can also be triggered by allergens, in which case we would call it acute spasmodic laryngitis, but both present the same way. You're going to see inspiratory stridor and a barky cough, typically occurring at night. So these kids will be hoarse because their vocal cords can actually be impaired. And they generally do look pretty unwell despite its non-emergent progression. So it can be really scary for parents. And because it often comes up in the middle of the night, you can just imagine how that fear is compounded when your kid is waking up at 2 a.m. and is making these, seal-like breathing sounds and just looking like they're in a lot of distress. I'm going to go ahead and play a clip here for what stridor sounds like. You can see the tugging as well on his neck. So, as far as etiology goes, while 75% of the cases of croup are caused by parainfluenza, other viral infections can also result in croup. Once you get into the older age groups, you can see some mycoplasma, but for exam purposes, keep in mind that croup is viral. So therefore, there are no antibiotics that we're going to be utilizing for croup. It is going to be supportive therapies. Croup normally affects kids in the 6-month to 3 to 5 year range, and more often in males. As their airways start to grow, then that swelling that they get doesn't impact them so much, and so we will see the incidence of croup decreasing. The cardinal signs for croup can be remembered with the mnemonic BLS for barky cough, low-grade fever, and stridor. And as I said, the sound that they're making with that cough and that breathing both sound very similar to like a seal because that airway is just so narrow that air going through it, it's like it whistles and it just makes just this very distinctive noise. Diagnosis for croup is typically through clinical presentation. In certain cases, we can use an x-ray to see that soft tissue swelling. And what we're looking for in those x-rays is what is called a steeple sign. And so as you can see here in this photo, the narrowing of the trachea can be shown on that black and white photo on the right side. You can see that little shadow where it kind of steeples up. It looks like the top of like a building, right? And that is indicating that the tissue in that surrounding area is closing off the airway, which is illustrated by the darker part of the imaging. Another tool that we can use are respiratory viral panels, and you can apply this slide to pretty much this whole week's worth of content because you're going to see this a lot during respiratory season and in the hospital. Almost all kids that are admitted to Carl with respiratory symptoms are going to be swabbed, although honestly it rarely impacts the type of care because most viral infections are going to be treated with supportive care and don't really require a specialized approach. So historically, these tests and swabs were done to determine isolation needs and cohorting possibilities. So in hospitals where you do have shared rooms, you will often utilize this information to make sure that you aren't combining children with two different infectious processes in one room where they can share, right? But Carl has private rooms, so that need no longer exists. But it's a fairly quick, non-invasive method, and parents often want to know, and so we are still checking just to see. And then obviously more recently with COVID, that is now included in that test, and because sometimes the care is going to be a little bit different in terms of anticipating complications, it's helpful to know what virus we are working with. So treatment is going to be based on severity. So most of these kids can actually be treated at home. Cool mist humidifiers are an option, making sure that they're staying hydrated. You can take them into the bathroom with the shower on, or equally effective is putting them outside in the cold night air. They can provide some relief by helping with that inflammation a little bit. More complex cases are going to include some nebulized medications like racemic epi, which is often used for stridor. We can also give steroids to decrease inflammation, and Decadron would be the choice there because it has a longer half-life, so it requires less frequent administration than prednisone. And then obviously for more severe cases, we are going to see some mechanical ventilation if they are severely compromised. And once again, it is important to note antibiotics are not needed for croup. Now, acute epiglottitis is a medical emergency. If that yellow explosion here didn't catch your eye. If you recall, the epiglottis is part of your GI tract, and it serves to protect your airway when you swallow by covering your trachea. But if it swells, then it can completely occlude the trachea and cause respiratory failure. Bad, right? So here's what it would look like through a laryngoscope. And so you can see on that right side how occluded that airway becomes when that epiglottis is swelling up. I mean, there's just barely a pinhole there, and it can continue to swell. So this is why epiglottitis is such a big deal. Unlike croup, epiglottitis is bacterial, mostly caused by H. influenza, which we're seeing decreased incidence of because it's included in your vaccine schedule, right? It's the HIB vaccine. So the children who are most at risk for epiglottitis are those that are under 5 who are unvaccinated, and it is actually now ironically increasing more in adults because adults can get it secondary to other bacterial infections like strep or varicella. Epiglottitis can also be caused from trauma or foreign body aspiration, so like any burns or caustic agents. If a child ingests something that damages their esophagus, then that can also cause epiglottitis. There is another mnemonic that floats around for epiglottitis, and it's add air nurse. So it includes, most of the symptoms, but the prominent ones are going to be that tripoding position, drooling, high fever, rapid onset, and inspiratory stridor. The diagnosis for it's going to be similar to croup based on your physical assessment. Okay, big exam point here. Do not do airway exams if you suspect epiglottitis. We do not want to do anything to stimulate more swelling in the airway. No tongue depressors, no fingers, no lollipops. Don't even think about looking in there with something in your hands, okay? Treatment is going to involve keeping the child calm so that they aren't working even harder to breathe, and then preparing to maintain your airway. Okay, we want to administer ordered medications. We want to educate the parents. We're going to be positioning the patient so that they can breathe properly, and we are going to anticipate intubation if it is needed. So the third thing we're going to talk about is foreign body aspiration, another PEDS issue that can result in obstruction of the airway, as you can imagine. It's most common in kids under 5. Because of their developmental lack of awareness, their curiosity and exploration, the fact that their airways are small, and even that they're easily distracted, right? They're going to run while eating. They're going to laugh while they try to swallow. And so the severity of the aspiration is going to depend on what was swallowed. A battery, for example, is going to be a much bigger issue than a pea that gets lodged. So initially, we would be looking for choking signs that you would learn in your life support classes, right? And then looking for respiratory symptoms such as wheezing, cyanosis, or inability to speak. If it's not urgent, we can do imaging to visualize the object and plan for a bronchoscopy to maybe go in there and remove it. But if that child is actively in distress, then we are going to do this. Our BLS tools, right? Back blows, alternating with chest compressions for infants, or we're going to do a Heimlich for older children. And if you recall, we're never going to blind sweep, but if you can see it, remove it, but otherwise keep your hands out. So for all obstructive disorders, we definitely want to reduce anxiety, which is difficult, right, between the child and the caregivers. And we want to make sure that we're providing education. We're going to make sure that we are keeping them updated on the situation and encouraging the caregivers to work with the children in providing those comfort measures so that they don't get agitated, because that could obviously make the respiratory situation more severe. We can promote rest on our end by clustering care, avoiding any unnecessary interventions, and then providing some calm distractions if that child is anxious. So we do want to monitor closely, but you have to weigh it against causing more distress by coming into the room. And this is where that parental involvement and remote pulse oximetry can come into play as well. Hydration is also important, just like with any infectious process. So we're going to be monitoring eyes and nose. We're really going to only use an IV as a last resort. Respiratory patients typically don't have IVs unless their intake is really low, or if they're really tachypnic and it's unsafe for them to eat and they can't have tube feedings because maybe they're not infants, right? If it's a toddler, for example, we're not going to be giving them tube feeds, but we will give them IV hydration while they are NPO. And so that is kind of the gist. The next lecture is going to focus on the lower obstructive disorders when we moving on down. Okay, have a great day.